The airstrikes that Israel has just conducted on Iran. I want to bring in CBS News Chief Foreign Affairs Correspondent Margaret Brennan. Margaret, I know that you are talking to your sources and gathering.
Are y'all able to hear me?
Yes, we've been trying to communicate with sources here in the U.S. and overseas. What we know is what the Prime Minister just announced, that these were Israeli jets targeting sites within Iran that he says were linked to the nuclear program that Iran has claimed.
Oh, great. Okay.
U.S. intelligence has been concerned about the.
We'll give it a few minutes. I know there was another session before this. Make sure everybody gets to log on.
Decided to pursue a weapon, and that it would take some time for them to do so. In his statement there, the Prime Minister said Israel's assertion is that Iran had stockpiled enough nuclear fuel for 9 weapons and that they could build one in less than a year. He did not explain why he felt tonight was the night it had to be done, that some of those targets were hit. I do want to point out that the Secretary of State, Marco Rubio, has released a statement making clear the United States did not provide support in terms of offensive support to this military strike. It didn't participate in it, but Israeli officials are telling me that the U.S. Was aware of Israel's intentions and these strikes. They were reporting that this throughout the day, it has been back and forth as to when a potential strike could take place. What we know at this point is just what the Israeli Prime Minister has detailed. We don't know yet if this completely kills the diplomatic option that President Trump said he preferred and was sending his chief negotiator to talk to Iranian officials about this Sunday in Oman. We hear from the administration that they think that diplomacy is in any way an option. Why would that still be necessary? Well, we don't know that Israel was able to actually take out the entire nuclear program. Iran has underground facilities that the U.S. is uniquely positioned to be able to destroy. And the U.S. has said that.
So let's go ahead and get started. I'm Dr. Lapage, and tonight we're going to talk about opioid and analgesic medications to treat pain. Most often, these are very commonly administered to our patients because one of the biggest issues that patients have that they seek treatment is because of pain. So one of the things, and I think we talked about this a little in our last session, pain is a symptom of something else going on. So while we need to control the patient's pain, we also need to find out what is causing that pain and what is the treatment for that cause or that whatever it is that's causing the pain. What is the treatment for that? So our outcomes for this session is we're going to differentiate the differences between opioid and non-opioid analgesic medications. We're going to apply the mechanism of action, the side effects, contraindications, and what assessment parameters do we need to follow or use, and what's priority assessments for those patients when we're administering them. And then of course, what are our nursing interventions to those various classifications of medications? Apply the appropriate educational parameters to be utilized when discharging a patient who is going home on those analgesic pain medicines, whether they be opioid or non-opioid. There's still always teaching that needs to be done. And then differentiate the differences between some pharmacological and non-pharmacological pain interventions. So, what is pain? Well, it's that unpleasant sensory emotional experience that has actual or potential tissue damage. So, think about it, if they are in a traumatic car accident, they're going to have tissue damage. They're going to have possibly organ damage, and both of those can cause pain. Might be a little different type of pain, And we'll talk about the different types of pain in a few minutes and how those medication classifications relate to the various kinds. Pain is very personal and subjective experience for that patient. Um, we tend to see a lot of stigmatism associated with patients who have chronic pain. So we really need to kind of take that out of consideration. It is very personal. Now we can clarify. Oftentimes, I see patients come into the emergency room and complaining of abdominal pain, and they're eating a bag of Cheetos or chips and drinking a Coke, and they're explaining that their pain is 10 out of 10. Well, I have to document that 10 out of 10. I have to take my personal feelings out of it, which would be you're eating, you're drinking, you're tolerating it. But that's also objective data that I'm looking at. And I can quantify that by stating patient eating Cheetos, drinking Coke in triage, relates pain 10 out of 10, no nausea or vomiting noted at this time. So that's kind of painting the picture for that patient. Remember, pain is our fifth vital sign, but also pain or our vital signs can also tell us a lot about the pain that the patient is in. Remember, anytime they're in pain or we're in pain, our heart rate's going to go up, our blood pressure's going to go up, we're going to be anxious, we're going to be acting a different kind of way. So, pain is whatever the patient says it is, existing wherever the patient says it does, and the intensity is, again, whatever the patient says it is. Pain is one of the most common reasons for seeking healthcare treatment, and it is one of the biggest complaints in the ER. And students will say, well, I tell students, and I think I said this the other night if you were on, that nobody has ever died from pain. Like nobody has ever died from a fever. And students will say, well, the pain of a heart attack. Well, that's true. That heart attack does cause that pain, but that pain is not what causes their demise. That clot that causes that pain because there's no oxygen flowing. When we talked about sickle cell in children, that was kind of the same thing. They don't necessarily die from the pain, they die from what's causing that pain. So we do need to address it accurately and assess it accurately and evaluate it accurately so that we can help that patient. Can be physical, it can be emotional. Emotional pain can cause physical pain, so we really need to keep that into effect as well. There is such a thing as broken heart syndrome. It's called um Takasumi cardiac um I can't think of the third name, Takasumi syndrome. And it's literally from a broken heart. These patients have suffered some type of trauma or emotional distress, and they see elevations in their troponin levels. But when they do a cardiac cath, they will not see any clots, and there's no cause for it. So it's typically occurs after a loss of somebody or any trauma that has caused them such emotional stress that they've had cardiac symptoms. So, what are our treatment options? Opioid therapies, non opioid therapies. We can use some non pharmacological interventions as well. And as nurses, that has to encompass or be included in our care. Sometimes we're doing some non pharmacological interventions like dimming the lights and giving comfort, warm blankets, or helping them change their position along with some of those pharmacological interventions as well. So they go hand in hand. There are several factors that affect pain. Age. Our younger children are not able to express pain, so they express it in crying, and they typically you'll hear that high pitched cry or a different kind of cry than what they normally have when they're just hungry or irritated or want somebody to pick them up. Our gender, sex plays a big role in it. We know males have less pain tolerance than females. So I think that's why females are the child bearers. Men tend to not deal with pain as well as females do. And a lot of times, us females, that's a disadvantage for us because we tend to kind of dismiss those aches and pains and we kind of move on, and it's often serious. So think about the pain of a chest pain and those presenting symptoms. They differ from male to female. So we really need to kind of be in tune to what's going on with our patients and take that into consideration. Race also has and their culture as well. They kind of go hand in hand. Culture, our men tend to be very stoic in some of our cultures, especially our Mexican cultures. They tend to not come seek treatment until they're almost dying. And typically, remember that pain is a symptom of something. So if they're in pain, they're still going to work, they're still moving on, and that can cause some problems. Socioeconomic class as well. That causes an issue with, again, poor management of some of that chronic pain. Does anybody have any questions or comments so far? No, everybody good? All right. So remember your pain, sensation, and relief. It all starts in your nerve ending. We have always seen this picture from way back in childhood, right? Don't touch the burning stove because those nerve endings in the fingers are burned. That transmitted up and down the spinal cord through the central nervous system to the thalamus to the cerebral cortex. And that's where our pain is. And in conjunction with our muscles, which is going to make us move it, right? Move our hand away from that painful stimulus. So, multinodal analgesic effects, you can see our opioids in particularly, and some of our non-opioids, but they all work on our central nervous system. The local anesthetics are going to be your NSAIDs or your COX inhibitors, which would be like your Tylenol and some of your NSAIDs as well. They do offer a synergistic effect, so that's a lot of times while you'll see those opioids with the acetaminophen or the opioids with the NSAID medications as well. Local anesthetics are typically just that, topical, or local anesthetic would be when you go to the dentist. They're going to put in that injection of that local medication so that it numbs that particular area. Think about childbearing if you're getting an epidural. Sometimes we combine 2 or more classes of these analgesics to target the different sites in the peripheral nervous system and the central nervous system. And that way we get a more maximized relief and could be less side effects depending on the 2 medications that they administer or prescribe. So we have classifications for pain. Acute pain is that rapid onset, it's varied in intensity. It warns the client that there's damage or some type of injury to some part of the body. It's going to trigger that fight or flight response, and it's going to disappear after that episode has resolved. It could be mild, moderate, or severe in intensity. So think about some things. What are some things that could cause some mild pain? What kind of injuries could cause mild pain to a patient? Come on, somebody knows. Anybody ever had mild pain or experienced mild pain?
Sorry, what is the question again? Like a headache?
A headache could be mild pain. It could also be severe pain, right? I was just trying to get you guys to get involved and answer, like kind of interact. The types
Well,
of
oh, I'm
acute
sorry.
pain.
Hello.
A burn. Yes. A
Okay,
burn
will cramps be one? Like the cramps that we usually
cramps.
feel on our
Cramps
legs?
would be one.
Yeah.
Exactly. Period pain. Absolutely. It could, and those could be from mild to severe as well. And remember, what might be mild for me might be severe for somebody else, but it's the same intensity. And it's also how we perceive it. Sometimes our past pain experiences also play into effect. Anybody had a bad experience? A fall is another one. Anybody have a bad experience with pain where it wasn't treated? Anybody have a good experience where your pain was treated?
The bad one will be a lower back pain.
Lower back pain? Yep.
Hmm.
Yep.
They don't
So,
fully recover from it. They just keep managing it.
right. So that would be more of your chronic pain where you don't recover from it. That would be more chronic pain because it's constant and it'll last more than a month. Um typically the acute pain lasts less than a month. Oh my gosh, yes. Okay, who said oh my god, yes? What do you want to share with us?
No, I was referring more so of the lower back pain
Oh,
thing.
yes.
So for people like us, like me, I'm a petite, but I'm sorry for the English, you guys, but my front is bigger, so I have bigger breasts. So my back, like in between the middle of my shoulder right there, always hurting. It doesn't
Yep.
matter whatever type of bra I'm getting, it's always like the pain is always there.
Right. And
Yeah.
unfortunately, that's going to be more chronic, right? You can have acute because it's really not going to go away unless you have some type of surgery. I have chronic upper back pain because I sit at a computer all day. It's certainly not because of I'm well endowed on the top, but it's because I hunch over and sit at computers all day long for a good portion of the time. So mine would be acute pain because it is episodic and it'll go away once I get a massage. But for yours, that may be chronic pain because it typically is going to last more than a month. And there's really nothing you can do about that. Sometimes good posture, right? Um, Fractures is another example of an acute pain. So when we talk about chronic pain, it could be ongoing and continuous, but the intensity of the pain, chronic pain can be acute on chronic. So for somebody like you were talking about that, you could probably get a little bit of relief over time by getting a massage or taking some medications. However, it's never going to go away. Back pain is one of the biggest causes of chronic pain. Bone pain, arthritis pain, there could be exacerbations. So these patients, a lot of education with when they come in and we have to ask them, what's your pain goal? Everybody wants their pain goal to be zero. But if they have lived with chronic pain at a 3, then our goal is to get them back to that 3, right? It usually will, that chronic pain will last 1 to 6 months or more or longer. It is unrelenting, like it's there all the time. And people, and you probably have tried to learn to live with it and accommodate. Sometimes teaching posture, sometimes exercising. Um, my sister she's younger than me, and she's a respiratory therapist, was a respiratory therapist. Easter Sunday, over a year ago, she was rushing a patient to the ICU and got tripped up and fell. And the way she landed in between the stretcher that she was pushing and the wall, she broke her hip and her right wrist. So that's going to be acute pain for her, but that acute pain lasted about 4 months with a lot of physical therapy. She wound up breaking her hip and her femur and her wrist in 3 places. So, as a result of that, she is now left with some chronic pain in that wrist and she can't work as a respiratory therapist anymore because actually the wrist was hurt worse than her hip and her femur. That kind of healed itself. They put plates in, but she has 3 different screws and plates in her wrist, and because she's a respiratory therapist and she could only get back 85% of the use of that hand and the movement, so she can't work as a respiratory therapist anymore because she intubates patients. So that's her chronic pain on top of it, especially with the wrist. Clients, they typically use routine medications to alleviate it. Thankfully, she does not. She does a lot of exercises and physical therapy. Referred pain is our third type of pain. And it's that pain we feel or the patient feels in another part of their body. And it's it's unparalleled to the area that it originated from. So a lot of times we think of, can you all think of any diseases or injuries that cause referred pain? An ingrown toenail. Yeah, those can be painful, can't they? Phantom pain is a little different, and we'll talk about that. That is true pain. So can anybody
I
think
don't know. I don't know if that would make sense, but I would think like a DVT can go into a pulmonary embolism.
yes, that would be your acute pain because that once we get rid of that clot, but that's more so. I don't know if that would be referred pain. I don't think it would be referred pain because with a DVT, you may have pain, but you typically don't have pain once it is in the lungs. You have more difficulty breathing. I've never really had anybody complain of pain with a pulmonary embolism. It's more so an acute onset of difficulty breathing, and we know that that clot has moved. And MI is one, right? That pain gets referred to from where? The chest to where? The left arm, the jaw, the teeth, the face in females. I've had people shoulder, exactly. Shoulder, upper back, yep, all good places. Or and good examples. As far as the shoulder pain, remember gallbladder pain can give you referred pain to the right shoulder in particularly. So good examples. So that pain that is referred pain, it is real pain. It is touching the nerve endings somewhere related to that area. It can be intense as well. So we talked about the different types of pain. I gave you some examples. Cancer pain is more often chronic pain. Arthritis, sometimes those migraine headaches. Neuropathy is more of a chronic pain. Your acute pain is muscle strains, broken bones, sometimes dental work and surgery, and then childbirth, right? Once you birth the baby, the pain hopefully goes away. We have some pain categories. That nociceptive is caused by tissue damage. So that's going to be your muscle strains and injuries or your contusions. It could be that somatic or visceral pain as well. The neuropathic is caused by the nerve damage. So that could be some of your facial nerves we have damage. Your neuropathies are going to be your neuropathic. The ischemic pain is what we see with DVTs. We see it with sickle cell sometimes because those sickled cells are not getting oxygen or perfusion to the whatever area that they're having that pain. We definitely see it with your MIs because that clot is causing insufficient blood flow to the heart and the major arteries. And then that referred pain is the pain that we just kind of talked about. How do we diagnose it? Well, it depends on the type of pain. A good physical exam. Sometimes we use laboratory exams and blood tests. With your MIs, with your DVTs, we'll do blood tests. Your gallbladder pain, we'll use blood tests. Pneumonia. Think about that sometimes. If they have a high white count and they have pneumonia, with that, we'll also use a chest x ray. But pneumonia can be painful, right? Your I just lost the word. Pleuritic chest pain. Sorry, it came back to me. Pleuritic chest pain. We might use your electrocardiograms and your EKGs to check for your MI pain. And then do a good psychological assessment. Sometimes these patients are having these pains, and it's due to stress, illness, death of a loved one. Get a good psychological history on these patients as well. I had a good conversation actually yesterday. I did the pain lecture with my face to face students, and one of the students was talking about our sickle cell patients and being frequent flyers. And I said, you really need to stop using the terminology frequent flyer. You really need to delve into why is this patient continually having to come to the ER or to the hospital, and why are they continually in a sickle cell crisis? So really taking the time out to look and see what's going on with these patients. A lot of times it's access to care. It's they can't get the care that they need to manage those conditions, so they're having these exacerbations that are causing the intense pain where they need to come in and be seen. I really try to get students and nurses to take the stigma out of a lot of our healthcare. Yeah, they may be frequent flyers and coming in a lot, but why? What's the reason behind that? So, anybody have any questions? Pressure injuries, yes. Kidney stones, absolutely. Kidney stones do cause a lot of referred pain to the lower back and around to the lower pelvic and abdominal area as well. Or acute pain considered unstable? Unstable as in the patient's hemodynamic stability, or I'm not real sure what you mean by unstable. Overall wellness. Well, think about people live with chronic illnesses and chronic pain. I have asthma, and that's a chronic condition, but I manage it well. So, do I think of myself as sick? No. I think of myself as having a chronic condition that has exacerbation. So, I think a lot of the psychosocial aspect of how these patients take care of themselves plays a role. Unstable, acute. So, again, pain itself, whether it be acute or any type of pain, is never going to be something that's going to kill or make a patient unstable. What would make them unstable is the pain associated with that heart attack. It's that heart attack and that clot in their arteries that is causing that pain, and that's what's making them unstable. It's not necessarily the pain, but it's the condition that's causing the pain. Think about appendix. If the appendix ruptures, that pain of that appendix rupturing is not making the patient unstable. What's making them unstable is the ruptured appendix, the infection, the loss of blood, the other things that go along with this. Most often, it would be the sepsis that makes it unstable and not the pain itself. Does that make sense?
Yes.
Again, angina pain doesn't angina pain wouldn't be unstable. There is unstable angina and stable angina. So your unstable angina, again, it's not the angina pain, it's the narrowing and the spasms of those coronary arteries that's causing that angina. So does that make sense? It's not the pain, but the angina, and angina is those spasms of those arteries. So when we talk about opioid agonists, they act on the specific opioid receptor sites in the CNS, the central nervous system. So they're going to cause a lot of CNS side effects. But sometimes those side effects are also what they do. So they'll cause analgesia, they'll cause sedation, and they cause that euphoric effect. Those could also be side effects if that sedation sedates them too much, and if that euphoria causes them respiratory depression. So we use them in combination. Sometimes we use like codeine with Phenergan, we use as a cough suppressant. So sometimes we use some of these opioids as cough suppressants as well. They come in different routes. So your codeine is either pill or liquid. The fentanyl is either a pill, we give it IV, and they also have patches and transdermal patches. Your hydrocodone or your Vicodin is a pill. The Dilaudid can be a pill or IV or IM. Demerol, again, could be a pill, IM, or IV. Methadone is typically a pill or a liquid. Methadone we used to use years and years ago in the 90s to help patients with their addiction to heroin, but it's become a very good pain medication for patients who have end stage cancer pain. Morphine, your MS Contin,
Professor, please,
morphine.
can you share your screen?
I thought I was sharing it. I am sharing it. Can you not see it?
No, I'm not seeing it either.
I don't know why. Let me try and share again. It's telling me it's sharing. Have you guys not seen the screens at
We
all?
can see it
Now
now.
sharing.
Okay, I don't know why it stopped. Was it sharing before?
No.
No.
Okay. I'm not real sure what happened there. Your morphine is they have liquid, they have pills or IV and IM. The paregoric is your opium, oxycodone, oxymorphone, and then tramadol, your Ultram. It is still considered an opioid medication, but it is one of the least addictive, and it is one of the ones that it doesn't work as well as some of the other ones. And then your combination, your oxycodone and your acetaminophen. These medications are contraindicated in GI obstruction because they cause constipation and decreased peristalsis, delirium, tremors, and then decreased respiratory effort, obviously because one of the side effects is respiratory depression. And then alcohol use or abuse, because it's the sedative effect of both of those. So our side effects, your constipation, respiratory depression, apnea, could cause cardiac arrest, could cause orthostatic hypotension, could cause depression, nausea, vomiting, diarrhea, hallucinations, and then sedation. What are going to be our nursing interventions? So we want to focus our nursing interventions on decreasing those side effects. So if we know the biggest side effect is constipation, we want to give them some increase their fluids and their fiber intake. If we know that it's going to cause a lower blood pressure and hypotension, we want to make sure that their blood pressure is high enough. Oftentimes, if patients come in with an MI and an acute STEMI, which is your ST elevated MI, which is a major heart attack, their blood pressure may be dropping so quickly because they're going into cardiogenic shock that we cannot give them pain medications, either the nitro or the pain medication, the morphine, because their blood pressure is so low. And we don't want to decrease that blood pressure even low. We need as much perfusion going as we can. We want to monitor their respiratory rate before we administer it. And then after administration, make sure that we're providing safety by putting side rails up, bed in lowest position, giving them the call bell and telling them to call us before they get out of bed. Definitely want to tell them to avoid driving and alcohol, and then monitor for their level of consciousness. And we kind of talked about the different routes. Your opioid agonist antagonists are going to stimulate those certain opioid receptors but block others. So we use them a lot with your moderate to severe pain, with your opioid use disorder. A lot of times they are transdermal, and they also help these patients to decrease their sensation of wanting the opioid fix or the opioid medications. They're absorbed after the IM administration. The peaks with the IV is very rapid, and they are metabolized in the liver. So we need to monitor the liver function, or if the patient has a liver disorder, they're going to be contraindicated in that patient. It does cross the placental and it does enter the breast milk, the placenta, I'm sorry, and it does enter the breast milk. So again, they're called contraindicated in anybody who has allergy to sulfites, and then chronic pulmonary disease because of that respiratory depression. And we do not use them in our acute MI patients. Some of the side effects: respiratory depression, suppression of that cough reflex. So if this patient has a pneumonia and we want him to cough up secretions, we're not going to be giving him these kind of medications because it's going to suppress that. They do cause constipation. They can cause some psychosis and hallucination, and then some impaired mental processes. So they work more so on the psychological part of the nervous system. And then loss of libido. Nursing interventions, respiratory rate, blood pressure, we're going to monitor before and after. Get a good pain assessment, and then evaluate their pupil size. Because remember, those pinpoint pupils or those unreactive pupils we don't want. Monitor the liver enzymes like we talked about. Your opioid antagonists is the medication that's going to bind strongly to those opioid receptors but not activate them. So they block those opioid receptors, and they're used often to get patients off of the opioids as well. They're going to reverse the effects of that opioid use or misuse, and they reverse the respiratory depression, sedation, and the hypotension. So the one we know most often is your naloxone. That's going to get the immediate reversal of that respiratory depression or that increased sedation. Your naltrexone, which is your Vivitrol, it works more so to keep the patient from wanting the urges to take and ingest those opioids. The Vivitrol is available by shot that they get once a week or once a month, depending on the dosage, or they can take it by a pill. It is contraindicated again in your pregnancy and your lactating women. Some of the side effects are going to be the same: nausea, vomiting, sweating, tachycardia. They can develop hypertension because, again, we're reversing those properties or those effects of the opioid medications. Can cause some tremors, anxiety, and dysrhythmias. Has anybody ever had to give naloxone, Narcan? Nobody's ever had to give it? So one thing you want to be very careful of, especially if this patient is misuses some of the opioid medications, because it will wake them up very quickly and they will sit up, like bolt straight up in the bed sometimes, and they can become quite aggressive because they're used to that sedative effect of the opioids. So now we're reversing it very quickly. So just make sure you're standing back, and your safety and the patient's safety as well. So those all fall under your nursing interventions as well. So some specifics of some of your medications. Your IVs is typically, or actually, sorry, of your opioid antagonist. Your IV route, it's an unknown peak, but its onset is in 2 minutes or within 2 minutes. So remember, we want that respiratory depression to be reversed right away. But again, that's going to make that patient sit up bolt right or be wide awake, and might often be angry. The duration is 2 hours. So think about, if somebody's on a PCA pump and we've been giving them PCA fentanyl, and we need to reverse it with that Narcan, we need to closely watch this patient as well for at least 2 hours, because this medication can wear off. But what's the duration of the fentanyl or the other medication? So they may go into, after the 2 hours, when the Narcan has wore off, we may need to give them more because they go back into respiratory depression. Your IM or sub Q is going to be about 3 to 5 minutes. And again, the duration is that 2 hours. So again, our nursing interventions, oftentimes when we have to administer Narcan, we watch these patients for at least 4 hours. Depending on what they come in for and why we're giving it, they may or may not stay for those 4 hours. They may walk out. We do want to monitor these patients for cardiac complications, because it can cause tachycardia, especially if they've had to have multiple doses. One of the biggest things here in the US is the synthetic fentanyl that is being distributed for some of our substance misuse disorders. So a lot of times the nasal Narcan, remember, we're giving it nasally, and if they're not breathing in, they're not being able to give it. Yes, it's going into the submucosal tissue, but they may not be getting it very well. And it does not work on those fentanyl. So these patients are sometimes getting more and more doses. We've had patients who have received in the field up to 5 and 6 and 7 doses of the Narcan before they've woken up or before it's worked. And then we see a lot of cardiac complications after, and especially in the emergency room when we're monitoring them before we get them admitted, because most often they need to be admitted if they're getting that much Narcan. But we start to see runs of ventricular tachycardia, which is abnormal. Any questions on these? No questions? Everybody's good? No comments? All right. So some of your non-opioid analgesics, they have several different properties. They can be anti-inflammatory, antipyretic, or analgesic. Some examples are your NSAIDs, your anti-inflammatory medications used for arthritis, and acetaminophen, and sometimes corticosteroids work. We inject corticosteroids into a lot of arthritis and knee pain, sometimes some back pain. We also give corticosteroids for chronic migraine headaches to decrease the swelling as well. So a combination of those types of medications will help. Your nonsteroidals are going to inhibit those COX-1 receptors, and that's going to result in decreased platelet aggregation, which can then lead to excessive bleeding. Can also damage the kidneys because it inhibits the COX-2, resulting in that decreased inflammation and the fever and the pain. But it does your COX-2 inhibitors do not decrease your platelet aggregation. So your acetaminophen is a COX-1 and COX-2 inhibitor. So we can use it for pain. We can use it for fever. Sorry, lost my train of thought. For pain and for fever as well, and it does not cause that kidney damage because of those COX-2 properties. But it does cause liver damage because it is metabolized in the liver. We use these to suppress inflammation, for mild to moderate pain, a fever reducer. They're anti-inflammatory, non-steroidal anti-inflammatories are really good for your dysmenorrhea patients. Silicosabid suppresses inflammation, and we use that with arthritis a lot. And in reducing that inflammation, it's going to relieve the pain. Aspirin is examples would be aspirin, ibuprofen, naproxen, indomethacin we use a lot with gout pain as well. Diclofenac, your Voltaren, is very good for arthritis. And then your ketorolac, which is your Toradol, we use a lot for kidney stones. The thing with ketorolac is we cannot give it to older adults in the same dose that we do younger adults because of the damage that it can do to the kidneys. And remember, as we age, the kidneys then start to decrease anyway. Some contraindications would be with your asthma patients or any patient that has a vitamin K deficiency, your patients who have peptic ulcer disease, because again, it can lead to that increased bleeding. Any patients with a GI bleed, you're definitely not going to give it to, or any patients that have allergies to aspirin or NSAIDs. And remember, aspirin is definitely contraindicated in children and adolescents with viral illnesses because the virus and the aspirin together can cause Reye's syndrome. One of the better fever reducers for children is going to be your Motrin or your acetaminophen and not aspirin. We don't typically use aspirin, even though it's classified as an antipyretic. It is not used as a fever reducer in the adult population. We use aspirin as the antiplatelet effect and not the antipyretic. So your side effects, GI upset, dyspepsia. So what are our nursing interventions going to entail? Well, we can give them with food, right? Cause abdominal pain, nausea, and then renal impairment. So our nursing intervention is going to be that we're going to be monitoring that urine output and their BUN and creatinine. Can cause fluid retention. So definitely want to monitor that because we don't want them to have further issues. Another side effect with your nonsteroidals is tinnitus, which is ringing in your ears, and then respiratory alkalosis. Aspirin signs and symptoms of aspirin toxicity can be sweating, a really high fever, which again, aspirin is an antipyretic, but a fever is not what we expect when we're giving it, right? These patients can go into acidosis. They might be dehydrated, and then a lot of electrolyte imbalances. So our nursing interventions monitor for occult blood in the stool And then tell them to drink at least 8 ounces of water when they're taking these medications. They still should be avoiding alcohol, and then monitor their eyes and nose. Some of your other non-steroidal anti-inflammatory agents, your acetaminophen is gonna slow the production of prostaglandins in the central nervous system. We do contraindicate, it is contraindicated with alcohol misuse or elevated liver enzymes and or hepatic dysfunction or disorders. Sometimes, depending on how bad the renal disease is, it might not be used with those as well. It does get metabolized in the liver, but if their kidneys are bad, it can't be excreted as well. Side effects can be nausea, liver damage, and then these patients can have a coma if they develop a or have a acetaminophen overdose. We see a lot of patients who are somewhat trying to attempt suicide, and they think, well, I'll take a handful of Tylenol. I really don't want to kill myself, but I want to get some attention. But in the end, what they're doing is they're really doing huge damage to their liver, and that can result. I've seen several young girls that were in a short-lived coma for a while because of the damage it's caused to their liver in an attempt to try and harm themselves or seek attention. So if they are toxic from that acetaminophen, it can cause that liver damage. They're going to have severe nausea, vomiting, sweating, right upper quadrant pain, because that's where the liver is, and then coma. And unfortunately, it can lead to death. I've been a nurse 36 years, and over 25 of it have been in the emergency room and ICU. But I've seen one patient die from an acetaminophen overdose because it shocked the liver so poorly. That person ingested a bunch of alcohol along with taking a handful of acetaminophen. We could never really determine the amount, but when we started doing acetaminophen levels, of course, we do them as soon as the patient comes into the emergency room. Her level was already very, very high. So the suspicion is she took quite a bit. There is a reversal agent. It's called N-acetylcysteine or acetylcysteine. The brand name is called Mucomist. And we also use Mucomist for some of our respiratory patients to induce mucus. It can be given inhalation, or it can be given liquid if the patient is awake. It does smell like rotten eggs. So the room will be aerosoled, smelling like rotten eggs if they're getting it by aerosol. And if you get it on yourself when you're administering it in the liquid form, you're going to smell like rotten eggs most of the day. Nursing interventions, we're going to monitor those liver enzymes. Ensure that the patient doesn't ingest more than 4 grams per day. That is the max dose. So if they are on Percocet and acetaminophen, because remember, Percocet contains acetaminophen, we need to really be calculating the max dose if it isn't already done by the pharmacy, or contacting the pharmacy and saying, hey, calculate the max dose for me because they're on Percocet and they're got Tylenol ordered. Monitor their hydration status and their pain level and vital signs. So, any questions? Why then is aspirin the drug of choice for Kawasaki? Because it's a different kind of disease process. I guess because of the fever. Yeah. Is that a fever? Oh, is that a fever emoji? Okay. Any other questions?
We don't know why it's not chose this moment in time, but we
You guys are quiet tonight. All right, so let's do some practice questions. A nurse is caring for a client with pancreatic cancer who is on morphine sulfate. What is the nurse's priority action? So remember, this is a priority question. So you may do all 4 of those interventions, but what is going to be the best or the priority action right now?
B.
B.
Yep. Because that morphine is what type of medication? What's
It's
the
The
class?
it's a
respiratory
downer.
depressant
Well, it's not a downer. It is a downer, but
is
what's
the
the
respiratory
classification?
depressant.
Opioid drugs.
Opioid, yes.
Opioid. Yep. Yep. So, if you were gonna put these in, oh, I thought I caught all my errors. If you were gonna put these in priority order, what would you do next?
Israel is in a weakened state because of the past attacks last year by Israel on
Fluid.
A.
systems.
Promotes fluid and
Yes.
maintain hydration.
Promote adequate fluid intake and maintain hydration. Yep. And then what would you do next?
C
C.
Check for
C.
sign of urinary
C and
Monitor the
D,
incontinence.
urine
right?
and then D.
Yep. Good job. A client with chronic pain is prescribed methadone. Which finding should the nurse address first?
B.
C. Prolong ECG.
B.
Yep. What? You are correct, but why?
It causes dysrhythmia.
Yes,
It
exactly.
is. Yep. It is a dysrhythmia. And none of the other ones are really going to harm a patient, right? They have a prolonged QT interval. They may have issues with cardiac issues, right? Constipation never really killed anybody in and of itself. Dry mouth, while it's uncomfortable, yeah, we'll give them some fluids, right? We can fix that. It's not the priority. And then pain 8 out of 10. Well, that's not good, but we can still fix that too, right? Good
Yes.
job. A client with arthritis is prescribed ibuprofen. Which symptom would require the nurse to take action first?
C.
Black stool.
C. Black stool.
Yep.
Yes.
They could be having a GI bleed.
You are correct. Yep. That stomach upset, the headache, and the nausea, those are side effects, right? So we can combat those with increasing their fluid for the headache. And then the stomach upset and the nausea, have them take it with food, right?
Mm-hmm.
A nurse is educating a student nurse about naloxone. Which of the following findings indicates its therapeutic effect?
B.
B. B.
B is in boy or D is in dog?
B as in boy.
B for boy.
Yep. B is in boy. That's the whole goal, right? We want it to improve their oxygen saturation. It's going to increase, we don't want it to increase sedation, and it's not going to decrease pupil size or bowel sounds. So it is B. A nurse is reviewing the chart of a client who is on acetaminophen 4 grams per day. Which of the following laboratory findings should be monitored?
C.
C. Hepatotoxic.
A.
As in Charles.
Yep,
C.
C is in
As in
Charles
cat.
because
Yeah.
that's your liver enzymes, right? And acetaminophen is metabolized by the liver. It doesn't affect the platelet. We would probably monitor the creatinine level as well,
Yeah.
but the hepatic function is more important. And then your hemoglobin A1C has nothing to do with acetaminophen, right?
That's a blood sugar.
What does that monitor?
Sugar. Blood sugar over 3 months.
Yep, blood sugar. A client taking meperidine should be monitored for which of the following complications? So remember, this is a select all that applies, so there's more than one.
Seizure,
Seizure,
respiratory depression,
hypertension, respiratory
depression.
So I heard seizures. That is correct. So that's serious, right? Hypertension. Why do you think hypertension?
I didn't say hypertension.
So do you know what meperidine is?
No.
Okay. So meperidine is an opioid. It's the generic for Demerol. So remember, our opioids typically cause hypotension, but meperidine doesn't typically cause hypertension. They're more known for hypotension. So B is not
C
correct.
and D.
C is correct. Respiratory depression. A and C are correct. Respiratory depression, obviously. D is not correct. It does not affect the hypo. It does not affect the blood glucose level.
A and C.
I'm sorry?
So it's A and C.
It's A and C. So also learning why the other answers are incorrect is really going to help you as well. It does not, meperidine does not cause gastric ulcers. What medications might cause gastric ulcers? This is an opioid. So opioids don't typically cause gastric ulcers. But what medication classification might?
NSAIDs.
NSAIDs. Yep, your non-steroidals. A client who received IV morphine 20 minutes ago is now difficult to arouse and has a respiratory rate of 8 breaths per minute. What is the nurse's next action? So you just assess the patient. What are you going to do?
Give naloxone.
What is it?
Yeah, give the antidote, naloxone.
B.
I hear B and D. So
B.
D for dog.
D for dog. Yes,
Naloxone.
D for dog. D for dog. Remember, it's a priority question. So it's what are you going to do? You're going to do all of these, but what is the very next thing you're going to do? You're going to administer that naloxone because you want to get that opioid reversed, and morphine is an opioid. Give me the route of or the sequence of what you might do next.
Oxygen.
Apply oxygen.
Oxygenist.
Yep. And then
Include
That would be
DBA. You call
DBAC.
the response
yeah.
team.
DBA.
Yeah, I would do DBA first, and then we may not even need to call the rapid response team, right? But the point of this question is you want to do what's best for the patient right now. You want to give them that naloxone. Calling the rapid response team isn't going to do much for this patient right now, immediately, because they got to get there, right? And the naloxone, anytime a patient is on opioid medications, you should have a naloxone. You should have access to naloxone very quickly. A nurse is caring for a client taking ibuprofen for osteoarthritis. Which of the following should the nurse monitor?
Potassium level.
D.
Why potassium level?
Osteoarthritis.
A, B.
So remember, your NSAIDs typically cause fluid retention. So we're not
Yeah.
going to lose potassium anywhere. The correct answers are A and B. So remember, our nonsteroidals affect kidney function. So that's our creatinine level. They also can cause bleeding because of that platelet aggregation, right? Or decreased platelet aggregation, right? So we'd want to monitor the hemoglobin levels. They don't affect glucose levels. They don't affect potassium levels. And your H. pylori is an infection that's going to increase the risk of ulcers. But unless the question says that the patient has peptic ulcers, we don't routinely do an H. pylori test. And that's typically done by an endoscopy. Does everybody see that? Any questions? We're all good?
Yeah.
A nurse is preparing to administer naloxone. Which of the following findings justify its administration?
B.
Employ people.
B is one of them. It's a select all that applies, so there's more.
D.
D.
Yep. B and D. Pinpoint pupils and that respiratory rate of 6 breaths per minute. So typically a good mnemonic less than 8, we intubate. So if their respiratory rate is less than 8, we intubate. If their Glasgow Coma scale is less than 8, we intubate to protect the patient, right? But we're not going to administer an opioid medication if their respiratory rate is less than 12 or less prior to administration. If it's less than 12, we're not administering it. Scratch marks on the client's abdomen, that's like a do nothing answer choice. Pain rating of 6. Well, naloxone isn't going to help the pain, right? And if we're having to administer naloxone, they probably don't have a good blood pressure to begin with because they're not breathing, right? A nurse is caring for a client receiving IV morphine for post-operative pain. The client's respiratory rate is 8 breaths per minute. Oxygen saturation is 88 on room air, and they are difficult to arouse. Which of the following is the nurse's next action?
B.
Yep, B. It's again, administer that naloxone and then apply the oxygen, and then you can start shaking them and call their name and make sure they're okay, because that would be your assessment, right? And then you're going to document the findings and call the provider. A client who received naloxone for opioid-induced respiratory depression is now awake but reports severe pain 9 out of 10. The nurse assesses the client's vital signs. Respiratory rate is 16, heart rate is 92, BP is 130/80, SpO2 is 96 on room air. Which of the following is the nurse's next action?
A. Okay,
C.
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 C. C as in
Give
cat.
the next dose. A. Everything is normal.
Yeah, C as in cat.
Yeah, it's C as in cat. So their vital signs are stable. Their respiratory rate is stable. There's no need to administer naloxone again. They're awake, right? Document the patient's pain level. That's kind of a do nothing answer choice, I call those, we're going to do that, but that's not the next thing we're going to do. We got to address the abnormalities that are there. He's 9 out of 10, right? But we're not going to give him another opioid analgesic if we just had to give him naloxone, right? We need to wait those 2 hours to let that naloxone get out of his system to see if it's going to have or if the other medication is going to still be in their system. So if we now give them an opioid, we're now prolonging that duration, right? So the answer is C. Encourage the client to ambulate to distract from the pain. Well, if they're in pain, they're not going to ambulate, right? So that's kind of a do nothing answer choice. A parent calls the clinic reporting that their 5-year-old child accidentally ingested several tablets of acetaminophen. The child is currently asymptomatic. Which of the following is the nurse's best initial response? So that's that double priority.
D. D as in
C.
dog.
C. C.
D as in dog.
Whoever
D.
said D.
D as in
D.
dog. D as in
Yep.
dog.
D as in dog. Yep. Instruct the parent to induce vomiting. We don't ever instruct anybody to induce vomiting. That's going to cause more problems. They could aspirate, especially a 5-year-old. And my kids are grown now, but I would never stick my finger down their throat. Anyway, that's just gross. And to me, that's ugh. Ask the parent to monitor the child for any yellowing of the skin. Well, that's going to be a little too late, right? Tell the parent to give the child grinded charcoal mixed with water. Well, depending on what the patient took, charcoal is not always indicated and it's not grinded. And we don't mix it with water to administer it. And we don't give it for acetaminophen. What would this child need if his acetaminophen level was high? What would be the antidote for that?
Acetylcysteine.
Acetylcysteine, yep. So advising the parent to go to the nearest emergency department immediately is what they need to do. Because we need to get blood work. We need to assess the child. We need to see where he is and do a further assessment before we do anything or tell the parent to do anything. Does that make sense?
Yes.
Does anybody have any questions? What is pinpoint pupils? Okay. Y'all got to speak up because I can't monitor the chat and the questions and show my screen. I have to go to 2 different screens. So pinpoint pupils, when you look at the pupils and you shine the light, they're going to be pinpoint. So it would be the size of a pen. They're very, very small and they're called pinpoint. When you look at your pen light, a lot of pen lights will show you the pupil size and they will show pinpoint. They're very, very small pupils. A client receiving patient-controlled analgesia, a PCA, with hydromorphone for acute pain is found difficult to arouse. With shallow respirations at a rate of 6 breaths per minute. Which of the following is the nurse's immediate intervention?
C.
Yeah, C. We got to get that medication to stop pumping because remember, a PCA pump is a patient-controlled analgesia machine. It's just like it looks like a little bit like an IV pump, but it's locked and there's keys and all of that. But that medication is going at what we call a basal rate. So it's continually flowing. And then the patient can push the button and get a bolus or a boost of the medication. So if we don't shut it off, that patient is going to continue to get that medication. we can shake the client and shout their name after we shut it off. And while we're shaking and shouting them, we could be putting on oxygen on them. Preparing to administer flumazenil is not going to do any good because hydromorphone is an opioid medication, and flumazenil is the antidote for your benzodiazepines. A nurse is educating a student nurse on morphine. The nurse understands that morphine primarily exert its pain relieving effects by
C.
Yep. It binds and activates to those mu opioid receptors in the central nervous system. So if you didn't know that answer of what they do, there's a couple keywords there. Morphine is an opioid, so you know it's an opioid, right? And it's got opioid in there. And the central nervous system. Think about all the effects of what morphine does. It works on the central nervous system. So if you weren't sure, those are your two key words that kind of point right to that answer choice. It doesn't inhibit your COX enzymes. That's going to be your nonsteroidals and your acetaminophen. It doesn't block nerve impulses in the transmission at the spinal cord because that would just be the area below. So that would be more like your local anesthetics or your nerve blocks. And then increasing the reuptake of serotonin and norepinephrine in the brain. What classification of medications does that?
Dopamine.
Well, dopamine does the norepinephrine, not the serotonin so much, but your antidepressants, right?
Yes, sorry.
A nurse is educating a client about managing constipation while on oxycodone. Which of the following statements is appropriate?
B. B as in boy.
Yep.
B.
B, absolutely. So we're not going to tell them to use laxatives daily. That's a little much, and they're going to wind up being dehydrated. We're not going to tell them to reduce the dosage because they need a prescription for that, right? And then constipation is an unavoidable side effect and will resolve on its own. Well, we all know that's not true, right? It can be avoidable by increasing fluids and fibers and taking stool softeners, right? A nurse inadvertently administers a double dose of acetaminophen to a client. What is the nurse's primary action?
D as in dog.
B. B as in boy.
Yep, B as in boy. Notify the healthcare provider. Yeah, you want to notify the healthcare provider because you're going to need possibly an order for the mucomist. They may tell you to draw some blood work. You are going to notify the client. Notifying the pharmacist isn't really going to do anything. And that risk manager, I assure you, is going to be made aware as soon as you fill out that incident report, right?
Mm-hmm.
The nurse is reviewing new prescriptions for a client admitted following a total knee replacement 2 hours ago. The client has a history of chronic renal failure. Which of the following prescriptions should the nurse clarify?
D.
D as in dog?
B as
Yeah.
in boy.
D.
Why B as in boy?
D as in dog.
Yeah, somebody said B as in boy.
The renal is not functioning, and you're still giving furosemide.
But how do we? He has a history, right? But do we not? We can give furosemide to patients in renal failure. We just have to monitor them very carefully. But ketorolac and furosemide is, we might be giving it to this patient because they've been given a lot of fluid, right, during surgery. So the furosemide may help get rid of that fluid if they're in fluid overload. But the ketorolac causes more damage to the kidneys, and it's contraindicated in patients with chronic renal failure. Enoxaparin is your low molecular weight heparin, and that is given because one of the biggest complications complications of a total knee replacement is a pulmonary embolism. And acetaminophen has no effect. So they may be taking acetaminophen. So the answer is D as in dog. A 5-year-old is brought to the emergency department with a 36% total body surface area burn involving the chest, arm, and abdomen. Which of the following analgesics should the nurse administer?
D as in dog.
Yep. D as in dog. Yep. We're not in looking at, you also want to look at your routes of administration. So we may give them some acetaminophen PO. However, it doesn't say this patient can swallow, right? Oxycodone IM, we're not going to administer any IM injections to a patient who has that much of a burn. He's 5 years old with 36% of body surface area. That's pretty significant for a 5-year-old. And then ibuprofen is probably not going to provide enough pain relief for that amount of burn and those areas. So the answer is D. A nurse is reviewing a client on indomethacin for pain relief. The nurse should question the concurrent administration of, and again, this is a select all that apply. Do y'all know what the classification of indomethacin is, or what it is?
NSAID.
It is an NSAID. Yep. So what's our answer choices?
B.
D.
So it's a select all that apply. Which one?
A and C.
A, B, and C?
A missed C.
A.
Prednisone and naproxen.
So let's look at these different medicines. So why would prednisone be questioned? Prednisone is a glucocorticosteroid.
Corticosteroid, yeah.
So why do we need to question that? They might very well be getting prednisone as well, because that's a corticosteroid and it's going to reduce swelling. Indomethacin is going to help with the pain. So we don't need to question prednisone. We don't need to question acetaminophen. Yeah, we don't need to question that because that is an analgesic. So he may need to take that as well. Naproxen is another NSAID. So we don't want to give 2 NSAIDs because of the chance of increasing the risk of bleeding. And then diphenhydramine is an antihistamine. Sometimes they do give diphenhydramine in conjunction with some medications to increase the effectiveness of it. So we don't need to question that one. Oxyprozin is another NSAID that's used for gout and some of your arthritises. So we would question that because it's another NSAID. So the answer is C and E. Does everybody see that? Any questions on it? Okay. A nurse is reviewing new prescriptions for a client who reports having an allergy to indomethacin. Which of the following should the nurse question before administration?
B for boy.
Yep, because that's another NSAID, right?
Yeah.
Acetaminophen again is fine. Oxycodone is an opioid, and that's fine. And then glucosate sodium, that's a do nothing answer choice. It has nothing to do with it, right? And we don't always have to question that. They may be on that for some other reason, right?
Mm-hmm.
A nurse is teaching a client on celecoxibid for pain relief. Which of the following statements indicate proper understanding? So this is a select all that apply. So you're going to have more than one answer choice.
C.
A, C.
No, hold on. Oh, I should stop making it fancy. Dark stool. Yeah,
A
C,
and C.
C, and
A
AC.
and C.
A and C, A and C, A and C.
Which
and
one?
C.
B and C? B is in boy and C?
A
A as
an apple, C.
A and C.
And C.
A for and C for cat.
Alpha Charlie.
So y'all are all over the place. So the answer is A and C. They're asking for proper
Yes.
understanding. So this is an NSAID medication. So remember, NSAIDs can cause stomach upset. So the patient saying, I'll take this with food to reduce stomach upset is correct. They understand how to take that medication. I can combine it with aspirin for better relief. Well, they both can cause bleeding because of that that decreased platelet aggregation, right? So that can increase bleeding. We don't want them to do that. So B is incorrect. C, I should stop immediately if I see dark stools. That's kind of the opposite, right? We don't want them to have bleeding, so they do need to stop it. So C is correct. D, we don't ever want to tell them to double their doses. That and that's typically not prescribed that way for your NSAIDs. And it's okay to drink alcohol with this medication. No, they should not be drinking alcohol. They shouldn't be drinking alcohol with any medication. So that is all I have. Do you guys have any questions, comments, concerns? Who's taking NCLEX soon? So the next session of what? For pharmacology or for so your sessions are on the NASLEX site. It'll tell you what sessions are next. I don't do another session until next Tuesday, and then next Thursday. Tuesday is childhood, and then Thursday is I gotta look. I don't. It's a pharmacology test taking strategies. What kind of test taking strategies? What are you particularly looking for? Good job taking NCLEX next week. Good. 2 of my students that I teach face to face that just graduated in May took NCLEX and both passed.
Yay.
Yep. So
Congratulations.
so congratulations to them, right? It's hard work on all of us, but for them the most, they're more stressed. So some test taking strategies. So first off, try not to be nervous. Try to keep your anxiety under control if you get nervous taking tests. Make sure you're reading all the questions and picking out those keywords. Kind of like if you don't know it, kind of rationalize it out. So like that one that we were talking about, so this one, if you didn't know what morphine does or what the actual action is or how it causes pain relief, look for those keywords. You should know that morphine is an opioid and it does work on the central nervous system. So if you weren't sure, I would pick that answer choice because of those keywords. Some other ones, so we've kind of like talked through what makes sense. So like this one, your priority is the patient is taking a double dose of acetaminophen. Ask yourself, what do I need to do for that? Well, that patient may need some mucomist, but we can't give it without the doctor, right? So out of my answer choices right there, notify the client, notify the healthcare provider, notify the pharmacist or the risk manager. So, yeah, talking to the client, but I probably would not talk to the client until I talk to the healthcare provider because now he's going to tell me, he or she is going to tell me what I need to do next. So, after I talk to him, he's going to say, draw lab work, administer mucomist. Now I need to go talk to the patient and say, unfortunately, you got a double dose of the medication. I've notified the doctor. This is what his plan of action is. And then you go from there. The pharmacist, that's kind of a do nothing answer choice. Ask yourself, what is the pharmacist going to do for me? Or the patient. Actually, what is the pharmacist going to do for the patient in this scenario of double dosing on acetaminophen? He's not going to do anything. Same with the risk manager, but I can assure you, once you fill out that incident report, that risk manager is going to find out about it. Make sure you're reading this other, there was another one that we, this one, make sure you're looking if they're asking for a medication in relation to a disease process or an injury, make sure you're looking at the route of administration as well, because for this question it would be I'm going to give an opioid medication, right? So we know oxycodone and fentanyl are both opioids, but I'm not going to give a patient who's got 36% of their body burned, I'm not going to give an IM injection because that's not going to be absorbed and we need to get them quick pain relief. So we know that IV is going to work quicker. So a lot of times students mess up or miss questions because they're not reading them completely and they're not picking out those keywords. When we're talking about priority questions, let me find a priority. So this, oh, we just did that one. So this one, immediate, that's a priority question. So ask yourself, what's the one thing I can do for the patient right now that's going to save or help them in this situation. If you don't know or you can't think of it, use your tips of is it an airway problem? Is it a breathing problem? Is it a circulation problem? Or is it a disability problem, which is your neuro? Well, that's not going to take effect in here, right? But this patient, we do have a respiratory problem. So, what's the one thing I can do to fix that respiratory rate? So, it's shutting off the pump and then administering oxygen and then asking the patient to shake and shout. So, that's part of our assessment. And then flumazenil, you do need to know that that is the reversal agent for your benzodiazepines. Your other tools to look at with your priority questions is ask yourself here with this question, a parent calls the clinic reporting that their 5-year-old child accidentally ingested several tablets of acetaminophen. The child is currently asymptomatic, which is a good thing. So that means that patient is stable, right? Which of the following is the nurse's best initial response? So read through them. And I tell students, look at your 2 answer choices. Instruct the client to induce vomiting. Well, we know we don't want anybody to induce vomiting, so I'm getting rid of that one. What I tell students is to pick between A and B or whatever your first 2 are. So ask the parent to monitor the client for any yellowing of the skin versus instruct the parent to induce vomiting. Well, I like B better. So I'm going to keep that one in my test bank or in my brain, right? And then I'm going to compare B to C. Tell the patient to give the child grounded charcoal mixed with water. Well, that's not how charcoal comes. And they're not going to have charcoal laying around their house. And charcoal is not the antidote for acetaminophen. So I'm going to throw that one out. So now I'm going to compare B, because I'm still thinking B, to D, because we know acetaminophen causes liver problems. So we may tell the patient to monitor the child for any yellowing of the skin. But then I'm going to compare B to D, advise the parent to go to the nearest emergency department immediately. So I ask myself, which one of B and D is going to help my patient the most? Well, in my opinion, it's going to be D, because that patient's going to be seen. We can draw blood work. They can admit, the emergency department can administer that antidote. Whereas B, that's just monitoring the patient. That's not going to do anything. Was that helpful?
Yes.
The person that asked, was that helpful? Sure. Okay. I like that. Any other questions? What do you do you all know what or anybody, have you identified anything in particular that you're struggling with that you might have a question about?
Can I ask a question?
Sure.
So, like, I know for like med surg, they say level of consciousness for a patient will be hello, hello, just to find out if they're awake, alert, and oriented. So, for like ER, do we just proceed with the medication, or do you have to check the level of consciousness first as well, or is it different?
I'm not sure what you mean by a difference.
So, like what I understand from my school is they say like in med surg area, because the patients are supposed to be conscious. Like when you want to assess them, like when you come into the room, the first thing you do is to assess them to know if they are like mentally alert or like just awake or kind of conscious. So like before you proceed on any medication or any treatment. So my question is like in ER, does it apply the same way? Or for example, the patient who is unconscious, like what do you do first? Do you assess level of consciousness or you just go ahead with the treatment?
So it depends on, so an emergency room is different. So if you're on a med surg floor and your patient is unconscious, you're going to do your BLS, right? You're going to shake and shout and do that. We do the same thing in the emergency room, but it depends on why they're unconscious. The the emergency room works a little differently. Nurses in the emergency are trained at a different level than a med surg nurse, and we work under protocols, so we can do more things without an order. We're covered under a broader order. So like I don't need an order to do an EKG. I don't need an order to administer acetaminophen to somebody who has a fever. I don't need to call the doctor and say, can I have acetaminophen for this child? Or go in front of them and ask them. I can actually put that in. It's called a protocol. I can input that into the computer and I have my order and it's covered by the medical director. So I can go in and start CPR and start administering life-saving medications because I'm ACLS certified and I work in the emergency room and I've been trained to do that. I cannot intubate a patient, but it just depends. I'm not going to do a full assessment on a patient. If they're unconscious, I'm going to go into my ABC, my ABCs, shake and shout, start CPR if I need to, get their airway by respiratory and that kind of stuff. Does that answer what you were asking?
Yeah, thank you so much.
Are you thinking of going into the emergency department?
Kind of. At first, I was like skeptical, but now I think I like it.
Yeah. What area do you live in?
I live in Houston.
Okay. Oh, that's a busy area.
Yes.
So did you go to school here in the United States or?
Yes, I did. I just graduated.
Okay. Okay. Did you go to the emergency room with your school?
During my clinical, yeah. One of the times we went to clinical, we had to go to Memorial Hermann. So I kind of liked it because it was really busy.
Yeah, I'm an adrenaline junkie. So I need that constant going. Um just a little bit about me. I was born in the middle of a hurricane in South Florida. And my father used to tell me his hurricane never went away. So, because I said it's because of that. I constantly, I need change. I worked in the ICU for several years, but seeing the same patients and doing the same thing over and over, I was pretty bored doing it. So in the emergency room, you're seeing a lot of different things, and if you really take the time to learn, you can learn a lot. There's nothing against med surg. I think it's a great area, but I fell in love with doing cardiac. I worked at Miami Heart Institute for a couple of years in Miami in my early career, and I fell in love with like heart and that kind of stuff. So the emergency room was the next best place. The thing about nursing is you can do so much in so many different areas and get a great experience. So, any other questions?
So my last question for you tonight is like I just stumbled into this Naxlex. Is that how you said?
Uh-huh.
So because I didn't know about it before, so somebody told me about it. So right now I'm using the promotional one, which is the 14-day trial. So but so far I like it. So my question to you will be, because I've taken the first assessment and I think you're kind of like the one giving the analysis for questions gotten right or wrong. I'm not sure, but I think it's the same face I'm seeing. So my question is this good enough to prepare one for NCLEX? I know everybody's gonna be biased saying mine is the best, but I just want an honest opinion. Like, is this good enough to prepare one?
So I tell my students that I teach during the day as well. There's so many things out there. Yes, I do think it's good enough. Yes, I do think it's a good company with their questions and their quality of questions. So I don't make up these questions. These questions come from some of the NASLEC test banks. I make up the content that I give you. They tell me what content and what areas, and it changes. I'm responsible for the content, but they give me the questions that come off of a lot of the NASLEX tests.
Okay.
I personally, I would not work for a company or a school that I don't think is good and will help the students. There's also a thing called too many resources. And students, even my full-time students or my daytime students, the ones at my full-time job, they want more and more stuff. I'm like, y'all don't need more and more stuff. Use the stuff you got, but use it correctly and what's going to help you. So a lot of times students just want to know the correct answer. If you're going through test questions, and that's why I tell you why the answers are incorrect as well, because that's helping you. So if you're using the product, whatever product you get or use, if you use it correctly, it is very beneficial to you. The quality of questions that are on the NASLEX site are questions that are just like NCLEX. So if it wasn't something I believed in, I would not work for them or, do stuff. So I think it is. I think you just need to practice. A lot of times it's students aren't practicing. I know it's a lot of work. I know that's the hardest test I've ever taken in my life was the NCLEX. And when I took it, it was not computerized. So I had to go 2 days, 4 hours in the morning, 4 hours at night, and it was a written test. And it was 180 questions each of those 4 sessions. So they've kind of tailored that. That's how old I am. We had no computers when I went to school. So the interaction that this program gives you is really good as well.
I mean, I took the first assessment. I kind of like it, and I mean, it kind of made me see what I know so far, and I was impressed with
Right.
my score. So I was just asking because I just finished my second assessment before I joined the meeting tonight, and I was happy so far. So I'm like, it kind of gave me that sense of you're doing good so far. So I'm
Yes.
like,
Yeah.
I don't want my hopes to be dashed.
No, and that's what you want. And then look at the areas where you didn't do so good and go back and study those or review those, right?
Okay, yeah.
And a lot of it is test taking strategies with NCLEX because you're applying what you know. Like they're not going to ask you what is a CBC. They're going to give you results of a CBC, and then they're gonna give you a patient scenario, and then you're gonna have to determine, okay, what do I do with this? So you're gonna have to do one step of the nursing process. So you have that information, you got the patient, you got CBC results, and you got a disease process. Now your NCLEX is gonna ask you your question could be, what are you going to assess related to that? What are you going to diagnose, nursing diagnose related to all of that? What are you going to intervene related to that? And that intervention could entail medications. What are you going to do to provide safety for that patient and all of that? So these questions do ask all of that. And there's the team from NCLEX is on, and he said, do all the RATs and CATs and you'll get an ultimate experience. Yep. In addition, attend the live webinars. It will suffice for a pass. Yep.
Okay, thank you so much. I really appreciate you.
You're welcome. In case you want to study Naxlex is good so far. Okay. Yeah, form your study groups if you live in Houston too. Yep. You can bounce ideas off each other because, you know, everybody has reasons. And the old saying, see one, do one, teach one, really, you know, do questions and then teach each other. You know, somebody
That is
pick
so
a
true.
topic and then you teach each other. All right. Does anybody else have any questions? Then I'm going to say good night, and I hope you guys have a good night.
Good night, Professor. Thanks for the explanation.
You're welcome.
Good night. Thank you. Good night.
Professor, can we get this handout? Is that possible?
Those are posted in the previous sessions.
Where can I get it?
You'd have to go on the Naxlex site, and you have to be a member or subscriber to Naxlex.
Okay, thank you.
You're welcome.